to ATCM, the emergency medicine channel. Today let us discuss about invasive fungal infections, that is invasive candidiasis. Invasive candidiasis means the blood shows Candida species or its complications including endophthalmitis, endocarditis, septic thrombophlebitis, renal candidiasis, hepatosplenic candidiasis and meningitis. So that means if blood grows Candida species or a major organ which grows Candida, that is a diagnosis that is called as invasive candidiasis. Most of the infection due to candidiasis is due to Candida albicans, but other species are also involved in this candidiasis, that is Candida glabrata, Candida parapsilosis, Candida tropicalis, Candida krusei. So these are the other organisms, but commonly we come across Candida albicans. Now, invasive candidiasis can be due to blood growth of Candida, that means blood culture growing Candida organism, or we already discussed that it can be due to a major organ involvement like endophthalmitis, endocarditis, septic thrombophlebitis, renal candidiasis, hepatosplenic candidiasis, or meningeal involvement of Candida. So even a major organ involved other than this also can be called as invasive candidiasis. Now we can see the risk factors like colonization of Candida at any site in a immunocompromised patient, presence of an indwelling catheter in a patient who is admitted in ICU who received long-term antibiotic or who is having an immunocompromised status, intensive care admission due to various disorders like malignancy, chronic liver disease. Any immunocompromised condition including HIV can also have candidiasis. Somebody is receiving broad spectrum antibiotics for a longer period or total parenteral nutrition also can develop candidiasis. Neutropenic patients can have candidiasis. Chronic steroid use also can develop candidiasis. Invasive candidiasis have got a very high mortality rate ranging from 5 to 71%. That means depending on the organ involvement and depending on the treatment, sometimes patient may not get adequate treatment because blood culture may be sent only for bacteria, so candidiasis will be missed. So inadequate treatment, depending on the organ involvement, the mortality can be raised up to 71%. Blood or tissue culture which can pick up a fungal infection, but remember routine blood culture may not be sent for fungus, it may be sent only for bacteria. So we have to specifically ask for fungal culture. And it takes time also to get a culture report, it always takes some time. Most of the patients who is having candidiasis can have candidial endophthalmitis. So every patient who is having suspected candida fungal infection or who have a candidial infection, we have to send the patient for a detailed evaluation of retinal examination. Then once we make a diagnosis of candidiasis by blood culture, after initial treatment and follow-up, we have to do repeated culture to know there is clearance of candidemia. That is very, very important. Sometimes the patient may be receiving a lower antifungal medicine. Patient may not be responding to our treatment. So whenever we get a candidemia, so after starting the antifungal treatment, we have to do repeated fungal cultures. Other adjunctive blood tests like beta D glucan assay, it's a cell wall component of many fungi. Adjunct to culture, we can do it. Sensitivity and specificity vary patient population. Another important test is mannan test assay. It is also adjunct to culture. Polymerase chain reaction T2 Candida assay also can be done. So these are the associated tests, but the best investigation in emergency room we can send a culture, blood culture for fungal culture if we are suspecting candidiasis, but it takes time. So when we have a patient who is having suspected invasive candidiasis or a proven blood culture proven candidiasis, candidemia or invasive candidiasis, the ideal choice is echinocandins. You can start drugs like micafungin 100 mg IV daily, anidulafungin 200 mg IV loading dose, then 100 mg IV daily, capsofungin 70 mg IV once as a loading dose, then 50 mg IV daily. So many patients may not afford this therapy. So after initial treatment, once the blood culture is sterile, we can switch to fluconazole. But in a patient who is having invasive candidial infection or an extensive blood culture growing candidial infection, fluconazole may not be sufficient. So you have to use echinocandins. Once the patient is stabilized and blood culture is negative, you can try to switch to fluconazole injections if the patient is not affordable. Otherwise, we have to continue the echinocandins for 14 days. Minimum is 14 days. Alternative regimes, if the patient is not affordable, we can go for fluconazole 800 mg orally or IV loading dose, then 400 mg, that is 6 mg per kg orally or IV once daily for those who are not critically ill. Amphotericin B lipid formulation, liposomal amphotericin B can be given 3 to 5 mg per kg daily. Potassium should be monitored during the therapy. Regular amphotericin also can be used if the patient's kidneys are normal. If there is no renal failure, regular amphotericin can be tried. If kidneys are abnormal, we can go for liposomal amphotericin or echinocandins. So minimum 14 days of treatment is required in invasive candidiasis, including candidemia. If patient is culture negative after a few days, 1 or 2 days, we can repeat the culture and it is negative, then we can consider to go for the alternative therapy like fluconazole if the patient is not affordable. Otherwise, same treatment should be continued for next 14 days. Now, once the patient is stabilized in ICU and if the patient require long-term therapy, then you can switch to oral therapy of fluconazole. You can give 400 mg loading dose, then 800 mg loading dose, then 400 mg can be continued. Or voriconazole 200 to 300 mg twice daily can be continuously given. But always see the culture and sensitivity. If the patient's culture shows a resistant strain to fluconazole or voriconazole, better not to continue the drugs. You have to continue you have to follow the sensitivity pattern and continue the drug. For some conditions require long-term therapy. That is a problem. Now, duration routinely, if blood culture is positive and blood shows candidemia, 14 days treatment may be sufficient. But there are some other conditions where you require long-term therapies like osteomyelitis 6 to 12 months, septic arthritis 6 weeks, Candidemia ophthalmicus, chorioretinitis at least 4 to 6 weeks, infected pacemaker, assist devices in ventricle, ICDs. Then you have to continue the treatment for 6 weeks after the device removal. Infective endocarditis by fungus at least 6 weeks following valve replacement or therapy, initial therapy, at least 6 weeks we have to continue. Suppurative thrombophlebitis at least 2 weeks after clearance of candidemia. So many of the invasive candidiasis require long-term therapy. The problem with long-term therapy is the cost. So we will not be able to continue echinocandins throughout this period. So if the patients, once the patient is stabilized and culture shows a sensitivity towards fluconazole, then we can change to fluconazole. But remember, fluconazole will not be sufficient in initial phase of the treatment, because if blood culture shows candidemia, then better to go for echinocandins as the initial treatment. And once the patient is stabilized and his sensitivity shows fluconazole sensitive, you can switch to fluconazole 400 milligram daily. That can be continued for the duration which is prescribed as per the slide. So we have discussed one of the most dangerous infection in emergency room and ICU. Many of the patients who is having malignancy or immunocompromised status, HIV, or those who are taking immunocompromised drugs like steroids, azathioprine, or mycophenolate mofetil, or newer anti-rheumatoid drugs. Many of these patients neutropenic patients, many of these patients can come to emergency room with suspected fungal infection. So when we are drawing blood for culture, always remember to draw blood for galactoman and other assays, fungal assays if possible. If not possible, take blood cultures only for fungal cultures, and fungal smear also can be asked if there is a pus or other body fluids. And when we are suspecting about a possible fungal infection, it can be treated with fluconazole. But if the fungal infection is proven with any of the methods which was described previously, better to go for echinocandins or amphotericin in invasive candidiasis than simple fluconazole. If it is not a very invasive candidiasis, local candidiasis, then we can go for fluconazole. And during the treatment, many of the patients may not be affordable to the echinocandins because they are very costly. So once the patient is stabilized, if there is no sepsis, if invasion is the amount of invasion comes down, we can switch to fluconazole or voriconazole depending on the culture sensitivity. And some patients may require prolonged treatment because fungus is always a slow grower. So even if you treat acutely, it may remain in the body because patient is continuously having that immunocompromised status. Afterwards, they can develop problem. So any patient who is having suspected immunocompromised admitted with sepsis, fungus should be suspected and cultures of body fluids or blood should be sent. Initial treatment always include fluconazole in a dose of 400 to 800 milligram as IV. Thank you.